Good morning. This is Sarah Sorum, Interim CEO of PSW, and thanks for joining us on today's PSW webinar on COVID-19 clinical implications. We're so thrilled to be joined by presenters Tom Dilworth and Lucas Schulz from Aurora and UW Health, and really want to thank them for, in a very quick, short turnaround time, putting this very popular webinar together for our members. We'll let Tom and Luke present, and then they've left plenty of time that we'll do some interactive questions. I'm going to turn it over now to Erica Martin on our PSW staff team to share how questions can be posed.
Hi, good morning. Yes, so we are going to collect questions for today. You can ask your questions by typing them into the question box, and then we will do our best to pose as many questions as possible. In order to get as many questions as possible, we are not doing the raise hand function today, and we are not unmuting anybody, but we will be moving through the question list and trying to group questions that are similar so that all your questions can be answered.
Great. Yeah, so let's save questions towards the end, but definitely feel free to send them as we're going. So my name is Tom Dilworth. I'm an ID pharmacy coordinator at Advocate Aurora Health based at Aurora St. Luke's Medical Center in Milwaukee, and I'm excited to talk about this ongoing pandemic with the membership of PSW and to be presenting with my colleague Luke Schultz from UW. So I'm going to do the first half of the presentation, then Luke's going to pick it up from there. And really what our objectives today are to review the current state of COVID-19, the pandemic here in the state of Wisconsin, discuss consideration and limitations of COVID-19 testing, and appraise available COVID-19 pharmacotherapy, and then leave time for your questions. And I probably won't do this justice. This was something that Luke integrated in our presentation, but really we want to dunk the ball of science over all the COVID misinformation that's out there. There really is a ton of it. And, you guys as pharmacists, you're really on the front lines engaging with physicians, mid-level prescribers, patients, other healthcare practitioners. And, we really need to be the source of truth on this. So hopefully you'll leave this webinar with a better understanding of what's true and what's not. So briefly, COVID-19. COVID-19 is the infection that is caused by severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. This is a coronavirus. There's a couple coronaviruses that are endemic in the human population. They cause mild colds. And then there was obviously the SARS outbreak a couple of years ago, mainly in Asia, also in Toronto. And then there was the MERS coronavirus in the Middle East a couple of years ago that had very high rates of mortality. So these are zoonotic viruses that jump ship into humans and can be extremely problematic in human hosts. What's interesting about the SARS-CoV-2 is its receptor point of entry in the human host is the angiotensin-converting enzyme 2 receptor, which is expressed near the surface of human epithelial cells, most notably in the lung, which is how this droplet-oriented virus infects human beings and transmits between human beings. So I'll come back to that a little bit later, and then Luke will really touch on it when it comes to the therapeutics. But I wanted to just talk for a few moments about the scope and scale of this pandemic right now in the United States. I don't know how many of you are familiar with this, but this is a website that's updated multiple times per day, put out by Johns Hopkins University, and they track COVID cases all around the world. And as you can see, the United States is currently leading the world with over 164,000 cases of COVID confirmed as of this morning, over 3,000 deaths. The crude mortality right now is 1.9%. That's likely an overestimation because we don't have testing capacity to test everyone. We're really only testing the sickest patients. When you look at the data that came out of China, the mortality rate was closer to 1.5%. But still, we are well above mortality for something like, for example, seasonal influenza. So this is a real pandemic. It's spreading rapidly, and it's causing a lot of morbidity and mortality, even right here. And if you look at the top under that 3,170, you'll see New York City, almost 1,000 deaths. There'll be over 1,000 by the end of today. So they are in wartime triage mode in New York City. It is getting real, and they haven't even peaked yet. So there's a lot of misinformation about there that this is a hoax or that this isn't real. No, I'm here to assure you it's very real. We are the epicenter of COVID worldwide right now. These are linear growth of COVID cases in the United States, and you can see in the faint font where Spain and Italy and China have leveled off. This is an awesome website on COVID-19 that just reimagines the Johns Hopkins data. And as you can see, there's a couple lines here. There's the COVID rate doubling every 2 days and doubling every 3 days. And then there's a faint line of 35% daily, which is basically how much the virus will grow if unchecked by measures like social distancing, quarantining, et cetera. So we are a little bit to the right of how the virus would naturally grow, which is good, but we're still somewhere in a doubling rate of every 2 to 3 days, which is extremely problematic in a country of 330 million people. In terms of Wisconsin, where does our curve lie? Now, this is a logarithmic transformation of the data. So if we did it linearly, the Wisconsin data would just look very small compared to some of the more populous states. But as you can see, we're still kind of between the doubling every 2 to 3 days, and that is even with the stay safe at home that Governor Evers has proclaimed now. This is a great study that I would encourage you all to read. So it was a preprint publication on medRxiv, which is a website that allows researchers to post their research ahead of peer review. This is becoming basically the way that COVID literature gets published nowadays. You have to be a bit suspect of it because it's not all great literature. This one's really good. This is a group out of the University of Washington, and they basically forecasted the COVID-19 pandemic and its impact on hospital bed days, ICU days, ventilator days, and deaths over the next 4 months, okay? And they did it by state. So this analysis is very sobering. It's remarkable in its scope and its granularity, and I've got the Wisconsin data up here for you. They're anticipating a Wisconsin peak. So surge in, the peak apex of COVID in Wisconsin is going to be April 27th. How accurate that is going to be remains to be seen, but these people are pretty smart and they model viruses all the time, and this is what they're predicting. So manage your expectations accordingly. We're looking at likely late April surge here in Wisconsin. We're looking at a shortage of ICU beds, and I don't know, it looks like we'll have enough hospital beds, and then the ventilators, we'll see if we do have enough ventilators. I also want to tell you one thing about this analysis. They're predicting 80,000 deaths in the United States by July. Now, to put that in context, in 2017, the height of the opioid epidemic, we had 70,000 deaths in this country alone. There were about 60,000 people, American soldiers, who died in Vietnam. So think about that for a second. 80,000. It doesn't sound like a lot. There's 330 million people in this country, but when you start comparing it to other things, it's a lot. So this is a very real pandemic that we're dealing with very real consequences. That's where social distancing comes in. I did have the opportunity to write a little bit of notes, if you will, that got posted to the PSW website about the importance of social distancing, but it is extremely imperative that you relay the importance of social distancing to everyone in your orbit, be that coworkers, colleagues, patients, family, friends. Do it via social media. We have to socially distance ourselves from one another to flatten the curve, as people say. There is no approved treatment for COVID infection, and Luke's going to dive into that and what that all means here in a second. The only treatment for COVID right now is prevention, and the only way you prevent it is with distance, social distance. It's a deliberate health strategy to spread out the volume and pace of viral spread that allows our health system to absorb these patients and treat them over a longer period of time. Many of these patients who are sick and critically ill are going to need ventilatory support, and if everyone came in at once, there would not be enough ventilators. And then you look at the wartime triage that's happening to some extent in New York City and happened to an absolute grave extent in northern Italy, where physicians were having to decide who's getting a ventilator and who's not. So you have to believe in this stuff. We have to spread this out, or we're going to be in a very dire situation. Now, I wanted to talk about testing. So testing has been a real thorn in our side here in the United States, and I'll talk about that in a second. But the standard right now is nasopharyngeal swabs. Anyone who's doing this needs to protect themselves. They need to have a mask. They need to have safety glasses, because there's a risk, obviously, to the healthcare worker that's doing this. Our testing capacity is not what it should be. It's not even close, guys. It's not even close, and I don't know if we'll ever get where we actually need to be when it comes to testing capacity. So the CDC and healthcare systems have followed suit with priority patient testing. So hospitalized patients who are acutely ill, healthcare workers with symptoms, patients on the ambulatory side with symptoms. You just kind of have this triage process of who's going to get a test. It is a reverse transcriptase PCR-based test. What we're starting to appreciate in Advocate Aurora right now is false negatives are possible. There's a couple reasons for this. One is patients who are early on in their infection or asymptomatic don't have a lot of virus, and that can lead to a false negative test. Specimen collection, it has to be done appropriately. It has to be a deep nasopharyngeal swab. If you just swab somebody's mouth, you're probably not going to get enough virus to be amplified by the test. And finally, specimen shipping and handling. This is becoming less of an issue as healthcare systems and hospitals are developing the capacity to test on site with their own labs. But for a while, we were having to ship these to SAIT or CDC. They had to be shipped on ice. And if they weren't, there was a potential that the sample would degrade and lead to a false negative. What everyone's recommending, most notably CDC, is if the clinician or you have a high clinical suspicion for COVID, you retest and do multiple sites, nasopharyngeal, oropharyngeal, sputum if you can get it, BAL if they are intubated, and try to elucidate whether or not the patient is positive. Viral cultures are not recommended. Viral cultures in general are challenging, and then there's obviously a risk to laboratory personnel safety with this highly transmittable virus. So on the bottom right here, I've sort of broken up the 4 buckets to which testing can be done. So it started with CDC. They had the first initial test, and then local and state labs were able to validate that same test, and they started doing it. But there was an extreme backlog as the pandemic kicked up. For example, there was a time where the Wisconsin State Lab was sitting on 1,000 tests, and they had the capacity to run 400 a day. And we were sending all our tests there. So we had patients languishing in the hospital, and we were waiting days to get that test result back. And that was consistent across the state. Now many sites have their own tests through emergency use authorization through FDA. They've developed a test, or they've replicated a test. They've submitted data saying it works, and they've been granted approval to use it in the context of patient care. That's drastically expanded our testing capacity and time to result, which is great. And then there's commercial labs like Quest, where if you have a lower priority patient, you can use a commercial lab, and then maybe you'll get a result within 5 to 7 days. I do want you guys to be aware, there's notes on PSW's website about this, is there is no approved home testing right now. So be aware of scams. If you're working in a retail pharmacy, you're working in a home health agency, there's no home testing kit for this right now. There probably will be at some point in the future, but not now. So FDA has a nice website, a compendium, if you will, of all the approved tests for COVID, and I would encourage you to look at that if you have questions. I also want to spend just a second, and I want to opine on this. These are my views. These are not those of Advocate Aurora Health nor the Advocate Aurora Health Pharmacy Department, but we missed the boat on testing here in this country, okay? There was a test available through the World Health Organization developed in Germany, and we didn't balk at it. We didn't take it. We decided to develop our own test. There was hiccups with that at FDA, and then it was slowly rolled out. And there was probably 5 or 6 weeks where we just weren't testing when we should have been. There was an index case in Washington. On the same day, there was an index case in South Korea. They ramped up their testing. Their curve of COVID does not look like ours, and ours is only getting worse. It's only going up. So we really missed the boat on testing, and I think the postmortem on it, in a couple of years from now, is not going to look great here in this country. We really needed to be out ahead of this, and we weren't. And I would direct you to this New York Times article that I've got on the lower left-hand side that really highlights that issue, and it highlights the plight of some researchers at the University of Washington in Seattle that were trying to ramp up testing and just getting mired in red tape with the FDA. So now I want to talk about this notion that ACE inhibitors and angiotensin II receptor blockers could make COVID infection worse or patients more susceptible to COVID. So I've got the renin-angiotensin-aldosterone system shown up here on the upper right, which you all remember for pharmacy school. And what's interesting, as I mentioned at the outset, is that the SARS-CoV-2 binds to the ACE2 receptor. Well, that first SARS coronavirus, SARS-CoV-1, also bound to the ACE2 receptor, and this led to ACE2 downregulation and increased angiotensin 2. Angiotensin 2 leads to sodium and water retention, elevated blood pressure, et cetera. It also promoted lung disease progression in a murine pneumonia model, or a mouse model that simulated pneumonia. Now, similarly, in a mouse model, exposing the mice to ACE inhibitors or angiotensin receptor blockers actually upregulated ACE2 expression by about 5 and about 3-fold when they were exposed to lisinopril and losartan. So that has led some people to believe that if you're upregulating the ACE2 receptor, you're giving SARS-CoV-2 more opportunity to attach and infect the host. Fortunately, this is not substantiated by any human data. It is an urgent research priority. You're going to see a lot of literature coming out in the next 6 to 12 months on ACE inhibitors and ARBs and COVID-19 and potential associations with outcomes. But again, ACEs and ARBs can reduce lung injury in viral pneumonias, as shown in that murine pneumonia model. And really, the cardiorenal protection of ACEs and ARBs in patients who need them and prevention of the deleterious effects of angiotensin 2, I believe, are really important for patients who get COVID-19 infection. And that's also important because patients with COVID-19 who have cardiovascular disease may experience worse outcomes. If you look on the upper right-hand side, these are data from CROI, the Conference on Retrovirus and Opportunistic Infections. It's an HIV conference held every year, but this was almost 20,000 confirmed cases of COVID from China. And as you look, you can see the disease severity. You have mild, severe, and critical in blue, orange, and gray bars, and then you have various comorbidities. And what's notable is those with hypertension, diabetes, and cardiovascular disease, as well as lung disease, had a much higher proportion of critical COVID-19 infection compared to other groups of patients. There's also a study, and I've shown the key takeaway from this study on the lower right. This was published in JAMA Cardiology just this last weekend, and this was looking at patients in China infected with COVID-19, and they stratified them, and they were looking at mortality, and they stratified them as with or without cardiovascular disease and or with or without a normal or elevated troponin. And what you can see is on the very bottom, the gray bar is the mortality rate, above 10%, less than 20% for those without cardiovascular disease and normal troponin. And it just kind of goes up from there. And at the very top, you'll see over 60% mortality for those with cardiovascular disease and normal troponin. So again, I do think there's probably a role for cardiorenal protection in patients with cardiovascular disease, whether it's an ACE or an ARB, if they are prescribed that. There's really no experimental or clinical data indicating benefit or harm with ACE or ARBs in COVID-19 patients, including those with cardiovascular disease. There's 2 ongoing trials at the University of Minnesota, one for moderate and one for severe COVID infection, looking at the impact of losartan versus a control, no losartan, on outcomes for those patients. And then there was also a preprint that came through this weekend that looked at just under 50 patients in China that were elderly with hypertension, and they saw a signal for some protection in those on angiotensin receptor blockers. But again, preprint, not peer-reviewed. I'm throwing it out there, but I didn't feel I needed to present that as its own slide today. So beyond those data, though, I think it's instructive to look at professional societies and where they stand on the uses of ACEs and ARBs in COVID-19. And as you can see from around the world, the consensus is continue or strongly encourage continuing ACEs and ARBs. Most important for us, American Heart Association, American College of Cardiology, American College of Physicians, and the Heart Failure Society of America. So if patients have questions about this, I would say you absolutely can continue these medications. Another myth that's sort of been spun out of control by social media and the mainstream media is that ACE2 upregulation by ibuprofen could be problematic. So this was mentioned in a letter to the editor for Lancet Respiratory Medicine with no citation provided. I did a little bit of digging, and there was a study in 2015, a murine study, that found ibuprofen could ameliorate the cardiac fibrosis in diabetic rats by reduction of the angiotensin-converting enzyme axis and enhancement of the angiotensin-converting 2 receptor axis. So again, getting at that notion that you're upregulating ACE2, and that's going to potentially, in quotes, air quotes, potentially make SARS-CoV-2 more likely to bind. This was promulgated by the French health minister, who suggested avoiding NSAIDs and COVID-19 on Twitter. That was back on March 23rd, and this gained substantial traction on social media. Patients were worried. They were worried about loved ones who were sick, who were getting prescribed ibuprofen, and it really was problematic. However, there's no published data to support ibuprofen avoidance in COVID-19. Here is a list of key organizations and individuals that do not recommend ibuprofen avoidance in COVID-19. The U.S. Food and Drug Administration, and I'll go back to their quote. They said there's no scientific evidence connecting the use of NSAIDs like ibuprofen with worsening COVID-19 symptoms. The World Health Organization and the European Medicines Agency, or EMA. And I thought the EMA was great because they sort of said what I've been thinking about this the whole time, is that when you're starting treatment for fever or pain in COVID-19 patients, you should consider all available treatment options, including paracetamol or acetaminophen and NSAIDs. Each medicine has its own benefits and risks, so it should be a patient-level decision, not based upon whether or not the patient is infected with COVID-19. I'll also direct your attention to the fact that 3 leading U.S. infectious disease physicians, world-renowned experts, have said you do not need to avoid ibuprofen. That's David Aronoff at Vanderbilt, Carlos Del Rio, and probably most prominently Anthony Fauci, who's currently serving an advisory role to President Trump's administration during the ongoing pandemic here in the United States. Very briefly, this is probably too simple for some of you, but I think it's important when we talk about NSAIDs versus acetaminophen. These drugs are available over the counter. They're often combined in combination cough and cold products. They're used by millions of patients. Patients don't often even know they're taking these meds, and they're a very common cause of acute poison center use, both intentional and unintentional. So it's important that we look at our patients and offer them the best advice possible. And really, there's a lot of people who shouldn't get NSAIDs, whether that's women in late pregnancy, patients with end-stage liver disease, systemic anticoagulation, patients with kidney disease, patients on ACEs and ARBs or have hypertension, patients with stomach ulcers, and then asthmatics should avoid aspirin, which is also an NSAID. I think a big point here that gets lost is, well, you can't use acetaminophen in the patient with end-stage liver disease or cirrhosis. And the reality is you can and you should, because NSAIDs are going to exacerbate coagulopathy and hepatorenal manifestations in patients who are end-stage liver disease. So you can give them acetaminophen safely. It just has to be 2 grams or less per day. So with that, I will stop and I will turn it over to my colleague, Luke Schultz.
All right. Well, thanks, Tom. Excellent job summarizing where we're at with testing and currently at the statements we have about ACEs, ARBs, and NSAIDs. I think those are really important things to consider as we're looking at how do we best care for our patients, that are coming into our pharmacies and asking us questions about that. I would start, and I start all my discussions when people ask me what should we be treating patients with COVID with the idea that we need to focus on providing excellent supportive care. So many people are asking, what do you think about remdesivir? What do you think about, nitazoxanide, or these very edge of the evidence therapies? And I always go back to the beginning of the only thing we can do necessarily is to provide good supportive care. The Society of Critical Care Medicine has put this out and has made their guidelines available. ASHP is making their guidance about providing excellent critical care available to pharmacists for free. And I think that's something we all need to consider, especially as those numbers that Tom showed are increasing, and we're going to have more patients treated in the ICU. Community hospitals that historically, intubated somebody, got them ready for transfer and transferred them to a tertiary care center, now may be caring for those patients for 5 days, 10 days in the ICU. So they'll be intubated and sedated, and we need to make sure we're providing those supportive cares. When we look at the evidence behind those provide more benefit than any of the therapies that we're considering to treat COVID-19. So can you make sure that you're minimizing delirium when giving long-term sedation? Are you optimizing the dosing that you're giving in patients that may be hyperdynamic? Recommending simple things like conservative fluid management strategies and low tidal volume ventilator management strategies are all important things to consider when caring for the critically ill patient. So I'll point out that, if you're I think as pharmacists, we're clearly not going to be, managing ventilator settings, but we should be prepared, especially if your hospital hasn't, historically cared for critically ill patients for a significant period of time. Are your supplies ready? Do you have enough benzodiazepines, enough fentanyl, enough other supportive care medications? And I would point you towards our guidelines that are available at UW Health. Look at the pain, agitation, and delirium. Look at the vasoactive agents. Are your nurses able and pharmacists able to appropriately titrate these medications to meet these MAP goals? So you can look there. Our COVID guidance documents are also available. So I know that that's not really the answer that people want to hear, right? Everyone, and I'm certainly in there. We want to be able to give our patients something extra. We're in America. We should be able to provide something additional for these patients. And one of the things that we're going to start talking about now are those therapies that are associated with it. And it's important to recognize the timeline of coronavirus and the onset. So this is taken from the Chinese experience, and it's been very similar with the Italian experience and the reports from New York, Washington, and New Orleans as well. So patients will start to have onset of symptoms at day 0. Before day 0, they may have been infected. They will have been infected probably 5 to 10 days before that. So it does have a period of time before you're symptomatic. So patients will have symptoms, and they may go several days with very mild symptoms. But and about 84 out of every 5 patients will simply have mild symptoms and may not need hospital admission. But about 14% of patients will wind up admitted to your hospital. This is 7 days into their disease process, maybe up to 12 or 17 days since the virus has started replicating. What we see is that patients go downhill very, very quickly. They can go from, hospital admission where their symptoms have gotten worse enough to ARDS and requiring intensive care admission within a matter of days. And this is something that's unique. So I want to point this out because it's going to impact some of the discussion we're going to have about the studies that we're going to talk about for the therapies. Here's a list of symptoms. These are, again, from the Chinese study and have been replicated by the Italian group and what we're seeing in New York as well. And about 5% of patients will go on to develop critical illness. And as Tom pointed out, there's about a 1% mortality rate. This is coming from the Canadian Health Organization, which has had better testing. So the 1% mortality rate is probably more accurate and accounts for some of those asymptomatic carriers. I'm not going to belabor this. Tom started this, but this is the progression of COVID-19. Here's the M spike protein is very important. It attaches to the ACE2 protein and is enveloped in an endosome. The target, the receptor binding, is a target for drug therapy. The endosome is a target for therapy. And then once it's in the endosome, the virus replicates using the host system's machinery, the RNA polymerase and machinery to generate new RNA and new proteins to generate a new virus. Those are created in the endoplasmic reticulum, and then those are put together and shed out of a host epithelial cell. So all of these are potential targets. The first drug I'm going to talk about is remdesivir. This is a broad spectrum antiviral agent that prevents the viral replication phase, so it stops it from replicating and generating more viruses. It's been studied in humans just very briefly during the MERS outbreak, and then it was studied during Ebola. But the data was very limited and often uncontrolled. So we don't have any data to say that it's effective in humans, but there's enough patients that have received it for us to say this is probably safe. The in vitro data and the cell line data that have studied remdesivir seem to be very promising for its use against SARS-CoV. Right now, it's currently only available through an expanded access program and compassionate use and compassionate use has been limited to pregnant women and children. There's a lot of considerations for who's excluded from these trials. So you've got to consider that most patients that wind up in the ICU and go into ARDS are probably going to be excluded from the expanded access program. And patients that you might be considering for compassionate use may have a delay of 3 to 4 days before getting the drug, and which will impact the effectiveness of this drug, because we want to get it started as early as possible, as I showed in the previous slide with the onset of symptoms to hospitalization to progression to ARDS. The earlier you can start a therapy and reduce viral replication, the less likely you are to progress. So a lot of people are spending time trying to acquire remdesivir and get involved in trials. If you've never been involved in a trial before, if you've never, or if you can't definitively say that you are ready to prepare and provide excellent and optimal supportive care, you're going to see more benefit spending your resources looking at how do we provide excellent supportive care. So a drug that is available and a drug that's generated a lot of controversy are chloroquine and hydroxychloroquine. We'll talk about them kind of as together because the mechanism is the same. There's some different dosing and things, but we'll talk about them generally together. So what these do is they accumulate in that endosome and change the pH of the endosome so that the virus can't uncoat and unwrap and allow its virus RNA into the cell to replicate. So it acts a little bit further upstream. It's had some evidence of activity in vitro during SARS-CoV-1 and MERS, and now data seems to be emerging almost every day about its use in humans. This is a very challenging drug combination because of the toxicity profile. There's a high risk for cardiovascular issues. So cardiovascular monitoring is certainly something we want to consider. And when we're talking about the toxicity of that, you need to consider who you're going to start giving these drugs to. It's easier, whenever you're deciding this, we're looking at a risk-benefit equation. What benefit am I getting versus what risk am I putting the patient at? And one of the things that we need to consider is that potential harm. For a hospitalized patient, and certainly in a patient in the ICU, we have continuous telemetry. We have the ability to monitor for cardiovascular toxicities. We can generally check labs daily. But is this something we should be considering giving to outpatients or for prophylaxis? Are we putting more people at harm associated with the drug, rash, cardiovascular toxicity, et cetera, than the small amount of benefit that we may be generating? So a lot of things are going into this. So much study is left to be done. I'm going to talk about the 3 studies just very quickly to get everybody up to speed that have looked at these. So the first one is that generated a lot of excitement was this French study that you gave patients hydroxychloroquine and looked at virologic clearance at day 6. There were only 36 patients, and what the results, if you only read the abstract, show that 70% of hydroxychloroquine treated patients were cured compared to only 12% in the control group, and that the addition of azithromycin made it 100% clearance. And this generated a lot of press, partially because of our president stating that this should be used for every patient. And I highly discourage us from taking recommendations from non-scientific people, because there's a lot of things wrong with this study, and this is a perfect example that points this out. None of these patients, this was not a controlled trial. Their control patients were just taken from 3 separate hospitals, so the care provided to them could have been substantially different. There was no report of baseline severity of illness, so we could not compare between those patients that received hydroxychloroquine and those who had controls, the small numbers there. Were the control patients less sick or were they more sick? Notably, 6 patients were excluded in the treatment analysis because they stopped therapy. So they did not have, as I mentioned, the outcome for this was viral clearance. So they did this via a swab. As Tom was talking about the testing for this, they swabbed the nose. And if you were unable to give a nasal swab at day 6, you were excluded. So when you look at why those patients were excluded, 3 of them transferred to the ICU, 1 patient died, and 1 patient stopped hydroxychloroquine due to adverse drug reactions and actually had their nose swabbed and were still PCR positive. So I would call every one of those a failure. The patients either progressed to the ICU, they died, or they had an ADR associated with hydroxychloroquine administration. And then the virologic clearance and the load was the wrong endpoint. Clearly, we know that some of these patients that wound up in the ICU or who did not do well had negative PCRs, and the 1 patient who had a positive, who died had a positive PCR. So there's some issues with actually looking at virologic loads and that they don't equate to patient outcomes. And then the addition of zithromycin was uncontrolled and seemed to be given randomly to patients without any background. There's a second study that came out of China. This was from the Shanghai Medical Center. This at least randomized patients to a control, which was good, improved the quality of the study. Again, this looked at a primary endpoint of viral eradication using the pharyngeal swab at day 7, and showed that 87% had a negative throat swab versus 93 in the control arm. So there was no difference in administering hydroxychloroquine for clearance of the virus in the throat swab. A few things that were concerning about this: 1, there was no control of the treatments that patients were given. There was a lot of traditional Chinese medicine that they simply referenced as traditional Chinese medicine. And so we don't know what other therapies they were given. That endpoint, again, as I mentioned, viral eradication is not accurate. This result that the negative throat swabs could simply have been that the virus progressed from the throat down to the lungs and was no longer active in the throat. So we don't know what happened to these patients because there were no report of clinical outcomes associated with these viral eradication studies. And then last night at about 10 o'clock, a new study came out. Again, this one's from a Chinese hospital that randomized and controlled patients to receive hydroxychloroquine, 31 in the control, 31 in the treatment arm, 5 days of therapy. Notably, these patients received quote-unquote antiviral agents, which I'm going to assume is a treatment for influenza. They also received IVIG and had the opportunity to receive corticosteroids, but this wasn't controlled. And we don't know how many patients received corticosteroids, and we know that these are recommended against for patients with mild disease. All of the patients that were included in this study had mild disease. They looked at time to clinical recovery, which only was the fever and cough, and then they had a secondary endpoint of chest CT findings at day 6. The results, just briefly, were that hydroxychloroquine seems to shorten the time to fever resolution by a day, and it improved the CT findings at the end of therapy by about 30%. So patients may have had a reduced inflammatory response, which is consistent with the mechanism of action of hydroxychloroquine, that it has some anti-inflammatory properties. 4 patients progressed to critical illness. All were in the control arm. 2 patients that received hydroxychloroquine, 1 had a rash, 1 had a headache. So balancing adverse drug reactions. Granted, these are very minimal and mild to patients progressing and getting worse and going to the ICU. This has not been peer reviewed. This is from the same MedRx IV site that Tom was referencing. So it's not been peer reviewed yet, but like we said, this is, I think, is a perfect example that the literature is coming very fast, you need to be very cautious and over-interpreting data, but looking at clinical outcomes versus virologic outcomes is very important as well. So a few points that I think could be take-home points. It's reasonable to administer chloroquine and hydroxychloroquine and give patients the best opportunity. It needs to be weighed against the harm that you may be causing patients. There's a huge ethics debate about whether we should be administering any of these without some guidance from controlled trials. Duration, 5 to 10 days. You need to consider your drug supply and how we're maintaining these therapies and providing therapies with proven benefit. Patients with lupus have a proven benefit of hydroxychloroquine. Are we sacrificing that proven benefit for an unknown benefit in treatment of COVID? And then making sure that we're minimizing risk whenever possible. There's no need, notably, to continue any antiviral therapy upon discharge. The patient's better. The virus and the viral replication has run its course. Continuing antivirals upon discharge is not necessary. As I mentioned, I would highly suggest reading this editorial published in JAMA from Andre Khalil about should we be using any of these medications. It really dives into depth about the harm and risk. But people, are always commenting, well, if you had unlimited supplies, who would you give this to? And I would start with hospitalized patients first, and then move to patients that had chest X-ray findings or clinical findings that were associated with worse outcomes. Right, we're looking at that risk-benefit equation and trying to balance who should be giving this to. We might see some benefit with patients that are already having clinical signs and symptoms, and then at-risk patients, all COVID patients, and then post-exposure prophylaxis would be next. So I think these are just some things that I would consider if your healthcare system or hospital has excess supplies. How would I tier my patients that I would treat them on? Very briefly, going to talk about lopinavir and ritonavir. There was one study published in New England Journal that was a randomized controlled trial of almost 200 patients. It showed no difference in clinical improvement, no difference in mortality, and more side effects with lopinavir ritonavir. The UW guideline, we haven't thrown this out yet as an option. Some hospitals have and said we're just not going to do it. Our virologists still think that there may be some promising secondary outcomes that this study wasn't designed to detect, but we certainly need more information about lopinavir and ritonavir before it can move up or be considered as first line. But if we're looking to treat somebody that can't take chloroquine, Kaletra may be an option if they can tolerate the drug interactions. So, as I mentioned, onset mild symptoms, hospital admission, generally mediated by the viral replication process. Once you start to move into this ARDS and intensive care side, most of the viral replication is done, and now we're into an exclusive immune response mediated process. So this is an anti-inflammatory response process. So our therapies are going to be directed towards those. I've already mentioned corticosteroids, not recommended for the use in mild therapy, but you may consider it in ARDS once a patient's moved into that overwhelming anti-inflammatory stage. Methylprednisone 60 milligrams IV daily is what's recommended for ARDS. And if you have a patient that's admitted for COVID who has asthma or COPD exacerbation, we should make sure that that you use the lowest dose possible. Using higher doses and unnecessarily high doses just lead to excessive viral replication as well. And one of the things that I think we need to be concerned about is telemedicine and this rise of telemedicine. And I don't want to ever forget some of the things that are proven. Antibiotic stewardship, for example. There will be a lot more prescriptions coming in for antibiotics for patients that are seen via telemedicine. Oh, you've got a cough. fever, maybe you have bronchitis or viral pneumonia or bacterial pneumonia, and we may be prescribing a little bit less judiciously with our antibiotics. So I want to make sure that if you're involved in telemedicine practices, that you're keeping an eye open for excessive antibiotic use. Tocilizumab has been explored and reported on for the treatment of this overwhelming anti-inflammatory state that we're calling cytokine storm. You may also heard it called HLH, or hemophagocytic lymphohistiocytosis. It's common with patients receiving CAR T chemotherapy. Tocilizumab is an anti-IL-6 drug that hopefully tapers that down. 21 patients in China received it. There's a few groups using it in New York and Seattle that have reported their experience as well. If you choose to use this, there's no data to guide us towards using it, really. But what you will see if you administer this is that the fever and clinical symptoms improve very rapidly in a matter of hours, and you may see a benefit for those patients. What we don't know is what happens long term with these. We know that from 40 years of data and study of ARDS and the inflammatory syndrome associated with septic shock, none of those immune modulating therapies have worked long term. So a lot more data left to be seen here. What you will see, I think, as a pharmacist, and what you should be looking for to monitor for the emergence of cytokine storm, is an increase in IL-6, which is generally a send out, so not available, but ferritin is a common level, fibrinogen. Ferritin goes to extreme levels, 6,000, 7,000, 8,000, very quickly as patients go into a cytokine storm. So these are things you can monitor for, and if you're going to consider tocilizumab. For the sake of time, I focus just on the drugs with human data. I'm listing the other investigational agents. These are things that I'm keeping an eye on because our hospital has resources. Again, I will reiterate this again, if you don't have resources to be able to provide excellent supportive care, focus on providing excellent supportive care. If you have extra resources, here's some things that we're exploring as well. So in summary, I'll leave this here. I think our work, there's a lot of work to be done. Just encouraging social distancing and PPE use, supportive care. Do we have what we need as pharmacies to provide that stock and be of value to make sure that there's product available to treat patients the best as we can? It's okay to tell patients to continue to use their ACE and ARBs. The benefit outweighs the potential risk, the very unstudied risk. Continue to be great pharmacists and stewards. There's a lot of things that we can be doing to make sure that we're not dropping the ball or losing sight of all of the other wonderful things that are proven benefits to pharmacy services and to great patient supportive care that we've done for years. Don't lose sight of those. Those are proven. All of these other therapies that we're exploring for COVID are unproven. I'll finish by saying thank you. This is a note that one of my neighbors gave to myself and one of the lab directors that lives next to me. And I think it should be shared and told to more people. So just thank you for trying to help people. We do appreciate it. I know you guys are out there putting yourselves at risk and putting patients first. So we all greatly appreciate it, and we are happy to take some questions.
Thank you so much. I will try to move through the questions here as we have about 10 minutes. So first question is regarding mortality. Hearing that people with other disease states that are positive for COVID-19 are dying due to causes of their other disease states, but they're added to the COVID-19 mortality rate. Can you touch on this?
Yeah, this is Tom. I can touch on that. We are in the throes of unprecedented and exploding pandemic. So I think once the dust settles on this, we can kind of go back and we can look at COVID attributable mortality. But I mean, the reality of it is it probably doesn't matter because they got a COVID infection. They ended up in the hospital. They ended up in the ICU. They ended up with ARDS. And whether, it was truly attributed to COVID or if it was something else or it was a decision to go palliative, the reality is they were alive before they got the infection and then they died. So that's the lens that I look through it right now. But it is an insightful comment that a lot of these patients are fairly comorbid and they may succumb to other sequelae of those comorbidities. I don't know if you have thoughts, Luke.
I think you stated it perfectly. I 100% agree.
Related to this, what comorbidities increase the risk of severe COVID-19, and what do we know about long-term consequences after recovery?
I think, some of the biggest comorbidities that have been sort of ferreted out in the literature and an anecdotal experience here in the U.S. are old age. So it's not really a comorbidity, but it bears mention. So the older you are, the more likely you are to die from this infection. It just goes up with if you're over 50, it's X percent. And then if you're over 60, over 70, over 80, over 90, it just keeps climbing. Diabetes, hypertension, cardiovascular disease, those are big ones. One thing that we're starting to see too now here in the States, which wasn't so common in China, is we have patients who are obese. And Luke can probably speak to this better than I can, but when you get a really obese patient on a ventilator, it's really hard to get them off of it. It's really hard to sedate them appropriately. It's hard to do everything appropriately because they are so large. And we're starting to see anecdotal data now suggesting that obesity is also a risk factor for worse outcomes. And it's probably collateral with diabetes as well, given the obesity.
And I would jump in for one thing too, that I think especially the ambulatory pharmacists, and certainly it's for everybody, but the age mortality associated with age and increasing age, it's certainly influenced by the aged population in China and Italy. They have their average age in China and Italy is a decade older than the U.S. So it is absolutely going to be influenced by that. And everything that I'm hearing from colleagues and friends in Michigan, Washington, New York, and New Orleans is that this is a disease that they are overwhelmed by the number of patients that are 30 to 40 years old, 30 to 50 years. How many of these patients are coming in very sick and presenting in their ICUs? So I think that will be something that eventually shakes out in the U.S. data, that mortality is actually much higher than expected in that 30 to 50-year-old range. So something to consider when we're trying to really encourage social distancing and people being aware of this, that it's that this isn't a disease necessarily of patients greater than 65, but it impacts 30 and above overwhelmingly. Not to say that there's not 20-year-olds that are showing up in the ICU. And please tell those stories to all the people that are the people that are not adhering to social distancing. Generally speaking, are the younger people as well that feel like they're not at risk for this.
And I think the other side of that, we don't have great data on long-term outcomes or sequelae, but I think if you just look at the overwhelming amount of literature that looks at, what's the patient experience like having survived an ICU stay, it's pretty bad. I mean, they have a psychological trauma. They often end up back in the hospital. So I think if you just look at that literature, you may be able to answer that question a little bit. But I think only time will tell how these patients do long term.
Great. We'll go to a couple of questions here. There's far more questions than we'll have time for today, but we will document them all and pass them along. one that has come up a couple times, though, is can these slides be made available on the PSW website for the citations? Is that possible that we could post these slides in addition to the recording?
Yes, absolutely.
Absolutely. And I'm happy to stay on, Erica. I can answer some questions after 12 o'clock if we want to stay on.
Okay, great. That sounds good. Yeah, we can go a few minutes over here. So I will go to the next one. So how would a lupus patient actively on Plaquenil, I'm sorry, I may have mispronounced that, be treated for COVID-19?
This is Luke. I would say that a lupus patient receiving Plaquenil should receive great supportive care. They can continue to receive their Plaquenil, their hydroxychloroquine during their treatment course. We would not expect it to change, or that therapy would need to change. They would be right now, based on the inclusion and exclusion criteria of the remdesivir trials, they would be excluded from those trials, from my understanding. So they may not be a candidate for some of these experimental therapies, but they should be treated as normal, just with great supportive care.
All right, we'll go to the next one. Is dextromethasone preferred over methylprednisolone in ARDS?
My short answer to that is any port in a storm. I know that all of these therapies, the corticosteroids, are becoming short. Supplies are becoming short. And we have very good data to show that the equivalence between those therapies. So you certainly could use dexamethasone if that was all you had for treatment of ARDS. Methylprednisolone is the only one that's been studied for COVID, or at least reported for COVID. Hydrocortisone is the SCCM recommendations, or at least they were historically for ARDS. So dexamethasone is getting a little bit outside of that. But if that was all you had and you needed an inflammatory mediating response, that would be certainly an option. Just making sure the dosing is correct, right? Because it's a challenge. It's not 60 milligrams. So as people are converting between the two, making sure you're doing that safely.
Right, the next one is, if a patient has asthma and COVID-19, what is recommended to treat joint pain if NSAIDs are not an option? Could they ask their doctor for a low-dose corticosteroid?
I think that's probably a patient-level decision. I mean, I think that I'd have to go back and look, but generally I think it's aspirin that you want to avoid in asthmatic patients. I don't know if they can get away with NSAIDs or not. You could definitely try acetaminophen. Otherwise, yeah, just follow up to see if there's something that could be done locally. Generally, I think the primary care physicians and the pulmonary staff are pretty familiar with alternatives in that population.
The next one is, how was the temperature cutoff determined? For example, some hospitals are allowing employees to work with temperatures up to 100 degrees Fahrenheit, while some patients are being diagnosed with temperatures below 100 degrees Fahrenheit.
Boy, that's a good question. I don't know, Luke, if you have.
I think that was a recommendation from the CDC that came up with the recommendations, and then each hospital needed to consider what the impact of that was on their workforce and their ability to provide care for patients. So I would address any of those specific concerns with your local incident command or who's ever leading that decision at your institution. They're generally taken from a population curve of where temperatures lie, where your normal temperature lies, but that is highly dependent on age and sex as well. So I'm not for sure where all of those came from, but
great. The next one is, please comment on possible autoimmune process in COVID. Is it possible that immunosuppressed patients may have less risk?
It is possible that they may have less risk, but we don't know that in a clinical study setting. Theoretically, a patient who's immunosuppressed may have a blunted immune response, and so that day 8, 9, 10, where some patients progress to ARDS and it moves into an inflammatory response system or process, they may have a blunted response, but this is all theoretical, and right now there's no data saying that they do better than patients who have a competent immune response, for lack of a better word.
The next one is, would you recommend a baseline EKG prior to starting hydroxychloroquine in the inpatient setting?
This is Luke. Yes, I would. We recommend a baseline EKG for all patients receiving it. A patient could have an EKG in the past 12 months as well. That would count for a baseline. The reason why we are allowing a historical EKG is that, we're trying to minimize the number of providers that go into the room and need PPE. That's our biggest concern right now, is that we have eliminated or are approaching, the end of our supplies for PPE. So anything we can do to minimize patient or providers being exposed and requiring the use of PPE, we should do that. So an EKG in the past 12 months, if they're starting new, then getting an EKG, and then you can monitor generally by inpatient telemetry. Most inpatient telemetries have the ability to do a calculated QT off of one of the leads. You have to just pick the right lead, which is generally lead 2 from a telemetry strip. There's a nice article that just came out of Mayo Clinic Proceedings that may change some of this, and it talks about the use of wearable devices and the ability of those to monitor heart rates and rhythms as a potential source of resources for monitoring some of these patients. None of that's been proven, but it's theoretical, and it's based off of the idea that some of these wearable devices are equally as accurate as telemetry in monitoring rhythms. And if a patient's certainly over 500 milliseconds, we recommend not using chloroquine. Anywhere with 470 to 500, consider not using it, but talk with cardiology and see if the risk outweighs the benefit. And less than 470, we're recommending it. And again, this gets back to that risk benefit. Is the risk of administering hydroxychloroquine to a patient with 470 to 500 worth it for an unproven therapy?
Great. We'll just do a couple more clinical questions here. So are patients with chronic kidney disease more likely to have more mortality, considering the ACE2 is found in the kidneys?
It doesn't appear. I assume Tom's not on. Are you there, Tom?
He did have to duck
had
off.
to leave, unfortunately, at noon. So
Okay, I just wanted to make sure I wasn't just jumping in and he was really itching to answer all of these. So the proclivity of COVID, for SARS-CoV is certainly to the lungs and the oropharyngeal epithelial lining. So it doesn't appear that SARS-CoV concentrates in the kidneys or would have a higher rate of infection or complications associated with the kidney. These patients often have higher comorbidities and more serious comorbidities, which we would think would lead to an increased mortality once they developed critical illness, but it does not appear that there's that the presence of more ACE receptors in the kidneys drives a more severe disease path.
And we'll do two more. So what data is there in the role of zinc in combination with azithromycin and hydroxychloroquine treatment?
That's an excellent question. Right now, there's no data specifically tying zinc treatment to COVID therapies. We've always talked about its use in the treatment of malaria with chloroquine, and it's generally recommended, but that I think has to do more with the anti-malarial properties of the drug, and it doesn't appear that there's a zinc-mediated receptor interface with SARS-CoV and the lung epithelial tissue and the ACE inhibitor and the ACE receptor. That's not a zinc-mediated process. So I've not seen any data that says that you need zinc or that zinc improves the activity of chloroquine or hydroxychloroquine.
All right, and this will be our final question for the webinar today. Apologies to everyone who we didn't get to your question. We have so many more questions than we have time, but we are capturing all these questions and we will route those and consider them for future communications through PSW. So please know that your question is being captured. We just don't have time for it on this webinar today. So the final question is, we are seeing a lot of treatment for CAP and COVID. Is co-infection common? Thus, these patients are on ceftriaxone and azithromycin and HCQ.
Very good question. The data from China seem to have a slightly higher rate of co-infection than what's coming out of Washington and New York. So there seems to be a relatively low rate of co-infection. However, the lack of testing supplies often leads to a broad differential diagnosis for patients presenting with respiratory diseases. And certainly here in Wisconsin, we are now ending our influenza season. I just saw the recent data, and we are on the back side of it. Our influenza numbers have dropped about 15% from the week previously. So historically, meaning like a week ago or 2 weeks ago, it was more likely to have influenza if you presented with a respiratory infection. Now it's a mix of community-acquired pneumonia and COVID would be on your differential. Influenza is still there. So if you can test and rule out any of those, there's probably not a need to treat for a co-infection if you can rule it out. If you can't rule it out, I think it needs to be considered. I would encourage that treatment durations are as short as possible, considering the use of procalcitonin as a way to monitor. That seems to be at least from some of the early studies, procalcitonin seems to be a mechanism to monitor for the presence of bacterial pneumonia. If it's low, then you don't need to treat. for a bacterial pneumonia with ceftriaxone or azithro, I would encourage the use of ceftriaxone and doxy as opposed to azithro, just due to the increased risk of cardiotoxicity. And then, if you have a patient that has a risk for resistant bacterial pneumonias, assessing them for that risk using a validated tool such as the DRIP score, to say, do they need vanco and cefepime or vanco and zosyn? If they don't have a high DRIP score, which means they have a low risk for drug resistance, stopping those two and de-escalating, and then limiting your treatment courses to, 3 to 5 days in most patients is like a reasonable approach if you can't rule out bacterial pneumonia.
All right, well, thank you so much for presenting this webinar today. Really appreciate it. As I said before, we are capturing all the questions for those of you who typed in, so we will document all of those. And I'll turn it over to Sarah for closing comments.
I just want to thank you, Luke, so much for, again, such a short timeline and putting this great presentation together and fielding all of those questions. And I know Tom had to jump off, but we certainly appreciate all of his effort as well. I'd encourage those on the line to check out the PSW COVID-19 website. We have a number of resources outlined there. Many of them are Wisconsin specific, including regulatory waivers as they're made available. And we're working very closely with the administration to identify what those pharmacy implications are that may need regulatory relief. There's also a recorded webinar on the PSW COVID-19 page from March 18th that includes some practice implications, including regulatory pieces. Some of that information is a little dated, but we are keeping that website up to date. We will be providing additional information and future call options available for individuals. I know that we maxed out our capacity on today's call, and we'll look to expand our capacity on future calls. Thanks so much, and we really appreciate everything that people are doing to care for patients in your communities.